Hereby, I open this academic ceremony at Maastricht University. First of all, I welcome Mrs. Sabrina Grossenbacher-Eggmann, and she will defend her thesis in public, Back in the Saddle, Early Training in Critical Care, Effects of Early Training and Evaluation of Physical Function and Activity in Mechanically Ventilated Critically Ill Adults. This is one of the longest titles I've ever seen. I welcome all the members of the degree committee, in particular the 4 supervisors, and they are sitting here in opposition to me. Professor Rob de Bies, Professor of Physiotherapy Research at Maastricht University, Dr. Caroline Bastiaans, she is Associate Professor at the Department of Epidemiology, also at Maastricht University. The co-supervisor is Dr. Martin Werra. He is Head of Department of Physiotherapy at the Inselspital in Bern and at the University of Bern in Switzerland. And Professor Stefan Jacob, he is Head of Intensive Care Medicine at the University of Bern and also at the Inselspital in Bern, also in Switzerland. Welcome to you all. And I will introduce the 6 opponents later during the ceremony. And of course, I welcome you here in the aula and all the followers of the live stream. Very welcome to you all. Mrs. Sabrina Grossenbacher-Eggmann, may I invite you to give a presentation, a summary of your thesis. Please go ahead.
Dear Prorector, dear Chair, dear members of the Corona, dear friends and family. I'm very honored to present to you my work from the last few years that led to my PhD thesis with the title Back in the Saddle. This means to return to living after a critical illness and is a highly relevant outcome to my patients. Can early training in critical care enhance this return? The last 2 years with the COVID-19 pandemic have put the spotlight on critical care units worldwide. Suddenly, everyone was very interested in the survival of critically ill adults. Mortality data was updated daily and rapidly became the main focus of the politicians as well as the public. However, critical care clinicians knew differently. Survival is not the only outcome after a prolonged critical illness. Patients kept telling us that they were grateful to be alive, but desperately wished to return to their lives. Indeed, previous research revealed substantial physical health impairments, for example, a reduced muscle strength or an impaired walking ability leading to falls and limitations in activities of daily living like bathing or shopping. These survivors reported a very poor quality of life that persisted over years. In my clinical practice as a critical care physiotherapist, I frequently observe the rapidly developing and profound muscle weakness that left patients completely dependent on functional tasks. They could not comb their own hair. They couldn't brush their teeth or pick up the bed covers to move them. When we assisted them to sit upright on the edge of the bed, they often could not hold their heads without assistance. They depended on mechanical ventilation to breathe and suffered from prolonged stays in critical care. These clinical pictures drove my research questions from this PhD thesis. First among them, can specific early training improve functional outcomes? How can I help my patients to return home? We therefore set out to answer these questions step by step based on our clinical observations that repeated exercises and intensive early mobilization slowly increased strength and functional ability in these patients. With time, they started to hold their heads again while sitting. they slowly regained their standing balance, and then gradually they could walk again. So to answer these questions in a logical way, we outlined 6 research projects that I would like to discuss on the next slides in more detail. First, we created a comprehensive trial protocol for a randomized controlled trial. This trial aimed to explore 2 different types of interventions in mechanically ventilated, critically ill adults who were previously living independently. The training group received a structured resistance and endurance training using in-bed cycling next to early mobilization and was compared to a control group that received usual physiotherapy, including early mobilization, for example, sitting in a chair. Our main outcomes of interest were patients' functional outcomes like bathing or walking in order to return back. This is a highly relevant outcome for patients in order to return back to living. The trial results are presented within the second study, whereby we found that the training group was not different from the control group in regards to the measured functional outcomes, such as walking or bathing. We did find a trend towards improved mental health that warrants further study. Additionally, we noticed that cycling was often prioritized over out-of-bed mobilization in the training group, which might have been an important limitation of our study. With the third project, we investigated the safety of the 716 conducted physiotherapy sessions. Critically ill patients are highly vulnerable and often very unstable. Thus, we needed to be sure that our interventions were safe and did not cause further harm. Overall, we found a large range of variation that requires close monitoring and individual tailoring of interventions to adapt intensity. There is not one size that fits all. The recommended training type and frequency to stimulate a cardiorespiratory response are active patient participation and mobilization, as well as shorter, more frequent sessions. However, clinicians need to be careful and ensure sufficient time for recovery after such a training. The fourth project ensued from the no difference results of our trial. We hypothesized that potential group differences might not have been captured by a global measurement like a walking test in a population that can barely walk. We therefore set out to identify a more fitting measurement for the evaluation of critically ill patients' physical function and activity. The CPACS, which was recently developed in the UK, seemed an ideal measurement instrument for our target population of mechanically ventilated, critically ill adults with a slightly prolonged length of stay. A physiotherapist can easily evaluate the CPACS after therapy, whereby the higher the score, the better the respective function or activity. After its translation and cross-cultural adaptation into German, we rigorously tested its measurement properties using prospective hypothesis testing as recommended by guidelines. We found that the German CPACS was highly valid and reliable. This means that the CPACS indeed measures function and activity, and also that it gives consistent results. We found that the CPACS was valid and reliable at all 3 measured time points, which were ICU baseline, ICU, and hospital discharge. The fifth project was all about returning home again. we hypothesized that the CPACs could be useful for the prediction of returning home within the next 90 days after ICU discharge. Indeed, we found that the CPAC score at ICU discharge could predict a return to home within 90 days, as well as hospital discharge destination. However, the CPACs was not useful to predict patients' quality of life 90 days after ICU discharge. In consequence, clinicians can use the CPACs to identify rehabilitation needs or to advise patients on their potential trajectories of recovery, including their return to home. The sixth and last project resulted from our findings of a high incidence of muscle weakness at ICU discharge in the trial population. When investigating the consequences of this muscle weakness on the measured functional outcomes like walking or bathing, we found that the poorer the muscle strength, the poorer the functional ability, and the longer the hospital stay. The most important risk factor that was related with muscle weakness during the critical care stay was in-bed immobilization. In stable patients, immobilization is a modifiable risk factor. Research on improving patients' mobility should therefore remain a target for future studies. So in summary, the 6 projects of this PhD thesis demonstrated that early exercise training combined with mobilization is safe, but not preferable to established usual care rehabilitation in regards to functional outcomes. The response to early training varies between patients and sessions. But overall, it does not negatively affect cardiorespiratory parameters or lead to further physiological instability. The German CPACS is equivalent to the English original and has excellent measurement properties, including newly established cross-sectional and predictive validity. Meaning the CPACS can be used across the whole hospital stay and is useful to predict a return to home. And finally, ICU-acquired muscle weakness was related to worse functional outcomes, which underlines the necessity of finding effective treatment interventions. At the start of this PhD thesis, I set out to answer questions from my clinical practice. Can specific early training improve functional outcomes? How can I help my patients to return home? The studies from this thesis contribute to the growing body of evidence for early rehabilitation in critical care. Although we do not yet know the most effective training intervention, we can give the following advice to critical care physiotherapists for their clinical practice. First, early training starting within 48 hours of ICU admission is safe. Second, concerning the type of intervention, it is better to prioritize mobilization over cycling and active interventions over passive movements. Third, shorter, more frequent sessions are more suitable to stimulate a cardiorespiratory response, but always allow for sufficient time for recovery. Fourth, intensity should be individually adapted and monitored to ensure safety. And fifth, regularly evaluate physical function and activity to identify patients' rehabilitation needs and to target interventions accordingly. While there are still some open questions for future research, for now, it's time to say thank you to all study participants, my supervisors, co-authors, my physiotherapy team at home, my friends and family. It was an honor to conduct this research. Together, we can assist critically ill patients, including those with COVID-19, back in the saddle. Thank you very much for your attention. I give the word back to the prorector.
Thank you for your clear presentation. The opposition will be opened by the chair of the Thesis Assessment Committee, Professor Martin Prins. He is Professor of Clinical Epidemiology at Maastricht University. Professor Prins.
Thank you, Mr. Prorector. Dear candidate, first of all, I would like to congratulate you, and with that also your honorable promotion team, with this fine piece of scientific work. It really is in a very difficult area. And I would like to start with a very simple question. And the question is, on your cover, I see a cyclist with a lot of hearts draining from hair and in the cycle. My question is that a picture of the patient cycling home, of the physiotherapist who has something more to do, or of the candidate who is happy to have finished her thesis? You can answer that with a very short answer.
Highly esteemed opponent, thank you for your kind words and for the easy questions to start. I think it is most likely me heading to work because I always rush and walk quickly. And also I had a lot of tasks that needed attending.
Okay, so you're saying my third option was the correct one. Well, I also have serious questions, and of course, as being a trial specialist, my questions are on the trial and on two sides of the trial. First, when you develop a protocol, there are always ethical aspects on designing a trial. And one of the aspects which really came into my mind and which I couldn't find in detail or in enough detail in your thesis is it really an ethical trial you did? Because severely ill patients do need a lot of energy to recover from their illness, to restore their body functions. And getting energy enough in patients is already difficult. In severely ill patients is already difficult enough. And usually severely ill patients lose weight, despite all attempts to feed them as properly as possible. And your active training and your mobilization very early will drain just more energy, which you can spend only once. So my question is, was this aspect discussed before you started the trial? And then how went the discussions and what was your decision or what was the conclusion?
The sound is a bit difficult, but you are asking me the energy, how was it ethical to consider the energy expenditure from these patients within the trial design, is that correct?
Yeah, rather than spending it to their bodily recovery from their illness, you gave it to the muscles.
Yeah, well, at the trial design, we saw already that these patients got better with therapy because they were so completely weak, they couldn't do anything and they were getting awake. And so that was our clinical findings. And so we found it ethical that we investigate this. But of course, we always had in mind that it needed to be safe and we do not increase energy expenditure. And that's why also we decided to collect the physiological monitoring, and we did the third project in the study. What I also thought that at the beginning of the trial, I wrote that in the beginning also from my personal experience in Ethiopia, where I saw what happened to patients that do not have physiotherapy. And so I was convinced that I do something good, but I was also very keen on checking that I do good and no harm.
Okay, I can find this answer correct, and probably your energy is not too much in short and not very intensive sessions. Okay, then I want to go to some aspects of the analysis, and I want to do that based on table 3.2. For your convenience, it's on page 56 of your thesis. Sorry, 66 on your thesis. And in the table, you first present a per protocol analysis, and after that, the intention to treat analysis. In statistical lore, when a study is open and the people who are around the patients know what treatment is given, it's quite usual to do an intention to treat analysis first and then look whether it's the same in sensitivity analysis. Can you comment on that? Why did you choose the protocol for first lines in the table?
Well, the per protocol analysis, I guess it has to do with the missing data that we had during the trial. And there were a lot of unexpected deaths, or the mortality was higher than we expected. So we had to impute a lot of data. And so my confidence in the end was higher in the protocol analysis, though results are completely identical. So I think we did a lot of sensitivity analysis to confirm our results, and they are robust.
Okay.
And that's probably why I put the per protocol higher.
You say they're completely comparable, but for a reader of table 3.2, that's quite difficult to see, because in the per protocol analysis, you use a non-parametric test with the median and the interquartile range, and in the intention to treat, you use an assumed normal distribution. Why did you use a different statistical test for those two analyses?
After imputation, it was normally distributed, so we could do a different test. And it was also another sensitivity analysis to confirm results that we are sure about that they are robust.
Okay, we could discuss for a long end, but I think my time is over, so I'll give the word back to the pro-rector. Thank you for your answers, and I look forward to further discussions.
Thank you, Professor Prins. The next opponent is also present online, not here, but online. She is Professor Carmen Fortmuller. She is Deputy Head of Research and Specialist in Intensive Care and General Internal Medicine at the Inselspital in Bern, and also affiliated with the University of Bern in Switzerland. Professor Fortmuller. Mute your microphone. Please unmute your microphone. We cannot hear you.
Excuse me. Thank you, Mr. Pro-Rector, dear candidate. Thank you for the good presentation and for your excellent scientific work. To start, I've got a few general questions. The first question is on the definition of prolonged mechanical ventilation. This is not an easy definition, so what steps did you undertake to come up with a definition, and how did you validate it?
Highly esteemed opponent, that was indeed not an easy question, and we discussed this in detail also at the beginning of the trial. And in the end, what most convinced us was that in Switzerland, or even in our unit, a prolonged stay is above 2.5 days. So that's why we decided on 3 days for both, or for all our trials. But I have seen other definitions. They range from 1 day to 6 weeks already, or even after tracheostomy. So we had to go on one definition, and then it was most appropriate to go for our own unit.
Okay. My next question is about the CPAC score. which you showed is a good tool to prognosticate on the state of the patient at 90 days. But to get the patient to 90 days, it usually needs more than, I say, just physiotherapy. There are also some other interventions. What is your idea about core interventions necessary to help the patients get to 90 days?
About my idea about the whole, or about the, I didn't understand.
Co-interventions, other interventions the patients need.
Yeah, absolutely. Physiotherapy is not the only intervention that patients need. For example, nutrition is also very, very important. You cannot really train without energy. So you need something for your muscles. And I also think, for example, the family is very important. The family at the bedside can often encourage patients as well. And that's also a reason, because there are other aspects of returning home within 90 days that we did not expect the CPACs to be a perfect match in our analysis. And so we thought there are other components that decide if a patient can go home, and that's why we expected an AUROC of 0.75 and not of 0.9, for example.
Okay, thank you. Then I've got another question on the CPAC score. Well, you showed that it might be valuable in patients who are very severely ill. But what is your take on other ill patients, for example, post-operative patients after a large surgery? Do you think it might be useful in that population as well?
I think it might be useful, but of course I have not tested it yet. So it would be a next question for further studies, of course. The same is for neurological patients. I think it might be useful, but also this population has not been, or the CPAC has not yet been evaluated in this population. So a measurement instrument, it's very important that you test it in the target population. And therefore I cannot fully say yet, but I think there might be a use for it, especially given that they also have a bit prolonged hospital length of stay. And we found that the CPACs is also useful at hospital discharge, but it needs further study.
Okay, this brings me to my next question. What is your next study? What do you plan to do next time?
I will do something on the CPACs. I plan to do first, well, we have implemented now the e-learning for the CPACs. So this allows all German-speaking persons from Germany, Austria, and Switzerland to assess the CPACs and to make an e-learning. It goes about 2 hours. And we are almost ready to launch it. And we will launch it with a survey, so it's going to be an easier study, but the study will be able to investigate inter-rater and intra-rater reliability from videos, from patient videos in the e-learning. And they will also help that we get some sort of feedback from all German regions. And then hopefully responsiveness.
Thank you very much. Sounds very interesting. I've got a few specific questions on the RCT you did. There you have a exclusion criterion, palliative care. How did you define it, and what did you do if a patient became palliative during ICU stay?
Yeah, well, palliative care, it was defined that we expected them to not survive until hospital discharge. And this was indeed very difficult to judge, as you know, and we often, at inclusion during recruitment, the study nurse and the physiotherapist always went to the treating doctor, and in the end, the treating physician decided about the expected survival or not. And this led to some exclusions of patients that did survive in the end.
Okay.
So this was a bit of a lessons learned also for next trials, because we need probably to define this even better.
Thank you. My next question is on the standard of care. Did you standardize care for your trial, for the standard of care arm, or did each physiotherapist decide on his own what he thinks best for his patient?
We decided on a pragmatic design. So the main goal is to, if we find that the cycling and the strength training was superior to what we usually did, then it would have been easy to implement. So it was very important that that it was also feasible to do in clinical practice. So physiotherapists were free to choose what they did, but they were not allowed to use the bike, because the bike, we bought the bike newly for the trial.
Okay, thank you very much. I will give back to the pro-rector.
Thank you, Professor Fortmüller. The opposition will be continued by Professor Walter van Mook. He is Professor of Postgraduate Medical Specialty Programs at Maastricht University, and he is also affiliated with the Department of Intensive Care of the Maastricht University Medical Center. Professor van Mook.
Thank you, Pro-Rector. Dear candidate, my congratulations, sincere on your work, well done. Very nice presentation, excellent scientific work. I think the thesis is unique as well. First of all, because of the very lengthy titles you chose, as the Pro-Rector already alluded to. On the other hand, it's also one of the most beautiful covers I've seen over the last year. So, but that's personal. I liked your focus. So you left out insulin, you left out feeding, focused on physiotherapy. And also the section on personal motivation for me was a creative novelty. So congratulations also for your supervising team. But there's always a but. I've got some general questions for you. In chapter 3, you mention that physiotherapy is limited to working days. So you physiotherapists, you've got a 9-to-5 mentality from Monday to Friday. We as intensivists, we work 24/7. Furthermore, the frequency of the interventions you did is relatively low and also a bit shorter in duration. So could it be that the benefit that may have resulted from your interventions during the working days from 9 to 5 with a low frequency and low intensity may have diminished over time over the weekend? So is that the reason why you didn't measure a positive effect in your studies? And should that perhaps, what would you suggest? Okay, can you give me first an answer, and then perhaps we can discuss a bit how you foresee the future in this respect?
Highly esteemed opponent, thank you for your kind words about my thesis. I agree with you. The exposure was probably too short, and it might be one of the important reasons why we have a negative trial. I can say that we were there often on the weekends, but you are right. Maybe physiotherapists need to start working more often so we can easier provide 2 treatments, for example, in the mornings or in the evenings. Like we learned a bit during the COVID-19 pandemic too, which we did also on weekends. But I cannot yet, there are trials from Brazil that show that this improves. But from us, I do not yet know, but it is a very good reason why it could have been negative.
But there was a conflict of interest there, huh? Because obviously as a physiotherapist, it's possible to do the physiotherapy sessions over the weekends. It's the same in our department. I have to push hard to get my physiotherapist in hospital in the weekends for exceptional patients. And it's a bit of a struggle every now and then. And so the personal interest of the physiotherapist is perhaps not aligned with the interest of the patients. So lower frequency on the one hand with a higher frequency on the other. How can we solve that issue?
Well, now we go into fields I have not investigated, but I love to
I
talk
know,
about
but
them.
it's a
Of
related
course.
topic,
It
so
is- it
I'll
is
ask
the-
anyway.
Yeah, it is the challenges we face nowadays. So it is the same with physiotherapists as with ICU nurses. We do not have enough staff. So we need more education. We also need to get physiotherapists motivated to work in critical care, because often physiotherapists are a bit scared of working in critical care because it is not well learned at school. That's why it's also important to get them postgraduate courses. That's certainly one reason. And the other is we need to get trials also that shows that it is better. Sometimes it might even be good to get a rest day, because our nurses, they often do a rest day on Sundays, where also we call it like a wellness day. So they get their hair washed, they get a foot bath, and so that also helps, I think, for patients to for their well-being, to get the motivation back to start on Monday. But also it needs to be an interprofessional aspect.
Right. So could it be an idea to have physiotherapists employed and primarily dedicated to the ICU?
Yes,
say
it needs
two full-time equivalents based in the ICU.
Absolutely. Well, we are fully dedicated to the ICU, but that's absolutely. But also, it needs not only the doctors and the nurses. It needs everyone to get the patient out of bed.
Okay. You didn't study it. I'll ask it anyways, but I'll touch upon another aspect you didn't study, but I'm going to ask anyway. Would there not be more benefit continuing the rehabilitation after discharge from the ICU? Because these patients will gradually improve. Maybe it's more ethical to rehabilitate these patients in the wards and perhaps continue it at home. What's your opinion on that? And I realize you didn't study it, but
exactly, I didn't study it, but I have an opinion, of course. And the opinion is yes, we need to continue. There was one study from Grutter et al. From Austria who did it with liver patients in the wards, and they improved. So they found a significant benefit. There are other studies like from Mel Meyer that in the Netherlands that training after the ICU also helps patients to find their way back into life.
Is there sufficient time for another short question? Short question. Very short question. You already alluded to that in your conclusion slides, I think, but could the interventional scheme you applied also matter? So what would you change for the future regarding the intervention you tested? Short answer, please.
Short answer. That's difficult to answer shortly. I do want to stay pragmatic, so it needs to be implemented, but then I would go probably mostly for goal-oriented, because that's easy to, you have the usual care and the other has a specific goal you train for every week.
But goal orientation is the aim and not the intervention, but I'll give the word back to the prorector anyway. I'm satisfied with the answer. Thank you.
Thank you, Professor Van Mook. The opposition will be continued by Professor Jok Aike. He is senior physician in intensive care and general internal medicine at the Inselspital Bern and also affiliated with the University of Bern in Switzerland.
So thank you, dear prorector, dear candidate. First, I would like to congratulate you for your very nice work, your very concise presentation with a large overview of all what you achieved during your PhD. It's a great work, great sum of studies that are well conducted. I have still some questions, so you may imagine. And maybe the first one, I was wondering, what is for you the definitions of early mobilization? Because I think so this is not very clear for me what is early mobilization. And so when I look for the definition in your thesis, I thought that it was linked to the physician in charge. And you know, there are several physicians in charge. And if they didn't, this was good to start with early rehabilitation, but you have residents, you have chief residents, you have attending, and all don't have the same view and maybe the same education. So how would you comment and discuss on this definition?
Highly esteemed opponent, thank you for your kind words about my thesis. It is indeed, I think it is also a limitation that we let the physician in charge decide, because it was not protocol guided and it was highly individual. So nowadays I would give clearer criteria. Having said that, I still like that we had that we didn't have strict limitations, like a patient with a blood pressure, middle blood pressure below 50 was not allowed to sit up. So that was not a fixed criteria, and I still like this because sometimes some patients are not allowed to get out of bed even though they can. So I think it needs to be something that is still pragmatic, but is clear, or that it is better protocol guided and not just based on individuals' decision. And the definition of early rehabilitation or early mobilization, as it is very difficult, and there was a large systematic review or scoping review from Clarissa et al. And she looked at over 100 studies, and each one used a different definition. And some use early rehabilitation, like I prefer, but there are also others like early mobilization, and it's not exactly the same thing. And that is indeed a huge problem because we do not talk about the same things. And following this study, I think it would be nice to do maybe a Delphi survey or something that we find international consensus of what early rehabilitation means. For myself, I defined it in the first chapter on page 27. For me, it's just starting in critical care as early as possible.
So maybe to jump on what you said, so we have in the ICU very structured visit with the nurse, but we don't have any with the physiotherapist. Do you think there is a place that we can define when to start, maybe to have something that is tailored to the patient?
Mm-hmm. Well, again, I have to say that I didn't investigate any of this, but so but yes, I think we need to be better at working interprofessionally and better to work together. There was one trial also from Schaller et al. That showed that goal-directed mobilization improved outcomes, and this was exactly the thing you just suggested, that when you set a goal in the morning and you reach it, patients get better. And so this is what we a bit implemented also in our clinical practice. So if a patient is ready to get mobilized, physiotherapists can say this early in the morning visit.
So now I would like to move on to the CPAC study. And so when I look to the study population of that CPAC study, I noticed that they are much more severely ill than the ones that you included in your first study. So can you explain why?
Yes, that is true. They were much more severely ill, and it has to do with the inclusion criteria. In the trial, we had the inclusion criteria of expected 72 hours. And this, again, like I said earlier, this was very difficult to judge. And in every trial, actually, in critical care, we are poor at prediction, I think. And so we had some patients, we included them because we expect them to stay for 72 hours ventilated, but they didn't. And that was a lesson learned. Try to go really for the long stayers, and then we defined only include them after 3 days. So then we really got the sicker population. That was our main target.
But then let's imagine you do such a trial design and then you wait until 3 days and you lose the early mobilization target.
Yes, that was also the reason why we did it in the RCT. But now I think we have shown that we can do it very early. So I guess in a future study, we can still say we have the same protocol, and we can say that was the first day of physiotherapy, but the intervention of the child maybe started a bit later, so it could maybe be done like this.
So maybe now, if we want to give a little outlook on this, so what would be from the lesson you learned from your thesis? What would be regarding an RCT? So let's say you have to revise your RCT trial design. So how would you change it so that it matches the knowledge you acquire?
So you asked about lesson learned, and well, there are many.
How would you design the next RCT?
Okay, because it is a bit different what I learned and how I would design. But because first of all, I would need funding, and funding would allow me to increase exposure. And for example, to have longer physios longer there, or physios over the weekend, or physios from ICU admission until a hospital discharge. So that would be, of course, nice. And I have thought about future RCTs, but I'm not yet fixed on the design. But I would use a very clear distinction from the control and intervention group, because that has to be shown that this is difficult when both patients have physiotherapy, and I do not find it ethical to withhold physiotherapy to some patients like the earlier trials did. And so it wouldn't need something to be clearly distinct. And outcome also that accounts for death, but also an outcome that accounts for the real problems like physical function and activity. For example, the CPACs would be very useful, of course.
Thank you, Professor Jok Eike. The following opponent is Dr. Patty Nelemans. She is researcher and clinical epidemiologist at Maastricht University. Dr. Nelemans.
Dear candidate, research in critical ill patients is a real challenge, and therefore I would like to start with complimenting you and your supervisors with your enormous drive to start and finish this research. But I'm here to ask you some critical questions, and I would like to discuss with you some methods that you used in the trial as described in chapter 3. And my first question is, why did you choose for 2 primary outcome measures? Because as far, we talk about the primary outcome measure, so it should be 1 outcome measure, but you used 2. And my question is, why did you do that?
Esteemed opponent, thank you very much for your kind words about my thesis. We chose, in the end, we chose 2 outcomes because I couldn't decide on the importance, because both were so important for my patients, and I couldn't decide which one was more important. However, at the start of this trial, I didn't have a lot of experience, and I would do this differently today. Mm-hmm. First of all, we have now 1 important outcome, which is for physical function and activity. So we have it all together. So we could use the CPAC. So that is a huge advantage. But at that time, the CPACs was not yet developed. There were no specific measurements for critically ill patients. And because I found activities in daily living and walking so important, we use both. Also, what I would do differently, we would have needed 2 sample size calculations. So we get 1 for, at least if you have 2 outcomes, we need 2 sample size calculations. So we have 1 for the 6-minute walk test and 1 for the functional independence measure, and then we would have taken the higher sample size. Mm-hmm. But there was no data available for the functional independence measure in critically ill patients.
But one of the outcome measures was activity of ability to perform activities of daily living, but there are measures, there are instruments to measure that.
Yes, the functional independence measure, which we used.
Yes,
It is a good measurement in the hospital, but it wasn't validated in critically ill patient. It has been used before in other trials, but it wasn't validated. And we did not found any data to perform a sample size calculation. And I also, when we did the study, we collected the functional independence measure at ICU discharge and hospital discharge. And at ICU discharge, there were a lot of floor effects. So we could not distinguish between patients.
But with hindsight, you would do it differently.
With hindsight, I would use one, and preferably the CPACs.
Okay, then I'm content. Then I have a second question. After the randomization, you had to exclude an extra 15 patients because you couldn't obtain informed consent. But my question is, why did you not wait with randomizing until you got an informed consent? Because it's never a good thing if you have to exclude patients after randomization.
I agree with you. Of course, that was not ideal, but it also has to do because we wanted to start very early. And so we could not wait on consent. It was the same to do. We had to judge 72 hours the expected mechanical ventilation very early. And then we also, because we wanted to start on day 1 or 2 after ICU admission. And so if we would have waited until we got consent from the family, because patients cannot give their consent in the ICU, treatment would have been delayed, and that would have been a major limitation as well. And now we are one of the earliest trials there are.
But does that mean that if you would do this trial again, that you would have the same problem, that you cannot solve it, that you always will have this problem?
It would be the same, but I think we could maybe do a back door or something. Like I said before, maybe we can, because we still want the target interventions. We do not want the ones who come to ICU for a day and then leave again. We want them, the ones who have real problems. So we see the ones who have real problems at day 3, but we treat all patients at day 1 already. We do that. That's our usual care. And so we say usual care is until day 3, and then the intervention starts. So that in the next trial, we can say until day 3, everyone has usual care, which we have shown to implement very early. And then the intervention starts. So that would help to get consent and also with the expected mechanical ventilation.
Okay. So there is hope for the future.
I certainly hope so.
Okay. A big problem in your trial was that there was a lot of attrition, as you call it, and many people were lost to follow-up. And you had to do something in your analysis about that problem. And in the intention to treat analysis, you used the multiple imputation of missing values, but in the PEP protocol analysis, you did something different. Yeah, you imputed worst outcomes for people who had died. And my question is, why didn't you use the same approach for both the intention and the PEP protocol analysis? Why did you use different approaches?
Yes, I think we could have done with the same approach. We prospectively defined that we will use worst scores for patients who died, but I also do not find it very ideal because a patient who cannot walk 0 meters in the 6-minute walking test also clearly different from a patient who died. So it is not really ideal.
No, it's not ideal, but
Yeah.
you could have done.
We could have done it in
imputation, and then you would have been consistent.
Yeah, we tried to do it because we had so much attrition. We tried to do it with several analyses. Like I did some sensitivity analyses and to see that do they differ or not. And in the end, they didn't differ. But you are right. It is a bit confusing two different imputations in the same table. It would have been,
No, it's not only confusing, I think it's wrong,
yes.
to be honest. But this is also, when you write a thesis, you have to learn, and you have learned a lot. So
Yes, I learned a lot about also never do or always make sure you do not miss any data.
so you learn by making mistakes.
Yes.
That's life. I give the word back to the prorector.
Thank you, Dr. Nelemans. The next opponent is Professor Ton Lense. He is Professor of Hospital-Based Physiotherapy at Maastricht University, and he is also affiliated with the Department of Physiotherapy at the Maastricht University Medical Center. Professor Lense.
Dear candidate, I also would like to compliment you on a very well-written thesis on a currently, in our profession, worldwide attention-grabbing topic. I would have a lot of more compliments and include your team, but time is running out, so I have to give you some questions. And you discussed it already with some colleagues about the content of the physical therapy you did. Because you wrote in chapter 2 that the control group received positioning, respiratory therapy, passive range of motion for non-responsive patients, and active exercises for responsive patients. And then your intervention group did the same with early endurance and muscle training additionally. What's the difference between active exercising and early endurance and muscle training? Because if I have to say it to my colleagues, you have to do active exercises and you have to do something else, does it turn out to be the same?
Highly esteemed opponent, thank you for your kind words about my thesis. I agree that in hindsight, it was also something that like I said, how would you do the next trial? Make very clear it is.
There's no money for a next trial, so.
Well, there hopefully will be, but make very clear that the groups have a clear distinction. And yes, and above all, we did that, and that we did very good. We had very clear manuals for physiotherapists, and each physiotherapist got an instruction on how to do it, and like what it can contain. So, for example, the intervention group, we said they need to go like this and this and this, and how you step up. But we didn't do it for usual care.
Okay, so I didn't read it anywhere. Was there a difference in hindsight, or was the contrast, well, really low? The contrast in time was really low because it was about the same amount of visits, a little bit less
Both.
in the control group, and there was, let's say, almost the same amount of visits. So do you have any clue if there was really a difference, or that you just had a RCT without really a contrast?
Well, there were small differences probably, but they were not large enough to measure potentially. If I'm completely honest, yes, I would say the difference was not enough. We would have needed much longer exposure like this.
Okay, then we leave it at that because I'm not asking you what you will do in the next study, but I can ask you, your boss is here, what should we do in clinical practice? What should we do in the intensive care ward? What should we do after leaving the intensive care? And what should we do after leaving the hospital? Because that's what should be the focus. Do you have any clues?
Well, now I have also to talk a bit about future studies, but what we found from our studies is to not prioritize cycling over out of bed mobilization, because the current evidence tells us to go out of bed.
But cycling is easy. Put it in the bed.
Yeah, right.
So
right. But that is certainly a huge finding. So do not focus too much on cycling. I still think cycling is important, but do not focus too much on cycling. Also do the early mobilization stuff and do it early in the morning. And then maybe you can still cycle in the afternoon, and use the cycle for patients who cannot get out of bed, who are too unstable.
Yes, I heard Dr. Van Mook, he thinks that you can also do it in the evening and in the night. So it's 24/7. So you can do that more. And then we as physical therapists also certainly say, but patients need rest. Not only ferrets. Then another thing, you say you would turn your therapy into goal-orientated care. I thought that was usual care already. Goal-orientated. I think in physical therapy, you always have to be goal-orientated. How else do you find things to do?
Absolutely. We have to work goal-oriented, and we do, of course, but I think we can do it even better. And we can do it interprofessionally also. Everyone from the team has the same goal. And the CPACs might also be useful for goal-oriented, because you see exactly the problems the patient has. So for example, it's sitting balance. And then you can set the goal for this week is sitting balance. And then you keep it you train sitting balance. You do other things, but that's the main focus on this week. And that's not yet what we fully do. So I think that would be an advantage of using the CPACs more often.
Yeah, okay, I understand. In the Netherlands, we have quite a discussion on, let's say, strength training didn't work. What is your idea about using, let's say, neuromuscular training, so electrostimulation?
As you see, Mrs. Grossenbacher-Eggmann, the time for defending your thesis has passed. The committee will now withdraw to discuss the quality of your thesis and the quality of your defense today. And please await our return with the results of our deliberation.
You've forgotten that.
Mrs. Grossenbacher-Eggmann. The degree committee here present, and also present online, has assessed the quality of your thesis and the quality of your defense. And in view of its positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. And Dr. Bastiaanse is authorized to confer upon you this academic distinction in accordance with Dutch university custom and law. And I invite your supervisor to take the floor. Dr. Bastiaanse.
Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
Yes, I promise.
By the authority vested in us by law and in conformity with the decision of the committee here present, I hereby confer upon you, Sabrina Grossenbacher-Eggmann, the degree of doctor and grant you all the rights attached by custom and law. As evidence of this, I now present you with the degree of certificate signed by the rector, the secretary, and the other members of the committee and affixed with the official seal of the university.
I could do this laudatio in English. Ich könnte diese Laudatio aber auch auf Schweizerdeutsch abhalten. Ich zou deze laudatio ook in het Nederlands kunnen doen. Aber unter Berücksichtigung der Sprachkenntnisse der unglaublich stolzen Eltern der Promovenda will ich diese Laudatio in der deutschen Sprache halten. So haben hoffentlich alle etwas davon. Ja, da stehen Sie dann, Dr. Grossenbacher-Eggmann. Wer hatte das gedacht? Wir? Ja, auf jeden Fall wir beide. Ist das etwas überheblich? Nein, auf keinen Fall. Es zeigt, dass innerliche Überzeugung, gesundes Selbstvertrauen und eine große Leistungsbereitschaft von Anfang an in hohem Ausmaß vorhanden waren. Und dann kam noch dein Talent, Intelligenz, Neugier, Sozialkompetenz, Leidenschaft und Leidensbereitschaft dazu. Eine himmlische Teufelssuppe, die erfolgreich zu diesem Doktorat geführt hat. Liebe Sabrina, genieße den Moment, auch wenn es gerade jetzt vielleicht noch etwas unwirklich zu sein scheint. Es ist nämlich wahr, du hast es geschafft. Und zwar innerhalb deiner zweiten persönlichen Deadline. Die erste Deadline, dein 40. Geburtstag am 6. November im letzten Jahr, konntest du wegen verzögerten Review-Prozess nicht einhalten. Ist das schlimm? Nein, überhaupt nicht. Das war doch eher so ein Ego-Ding. Und sind wir ehrlich, obwohl es in der Geschichte der medizinischen Wissenschaften diverse Beispiele von Ego-Dingen gibt, waren die in den wenigsten Fällen tatsächlich und längerfristig zielführend. Deine zweite persönliche Deadline hast du jedoch bravourös geschafft. In diesem Sommer möchtest du nämlich mit deiner Mutter, die leider nicht mehr bei allerbester Gesundheit ist, nochmals eine längere Reise machen. Vielleicht sogar zusammen durch Kanada. Mit deiner Mutter, die, so wir in der Danksagung in der Danksagung deiner Thesis lesen konnten, dich bereits in deinen jungen Jahren mit Ausdauer dazu motiviert hat, Algebra selber zu verstehen zu wollen. Neben der Weitergabe ihres genetischen Materials eine wunderbare akademische Lebensweisheit. Eure gemeinsame Reise steht nichts mehr im Wege. Dick meinerseits, vergiss unterwegs nicht, deinem Ehemann Jerry ab und zu mal eine Karte zu schicken. Ja, in einer Laudatio geht es einerseits darum, die getane Arbeit der Promovenda zu würdigen. Andererseits sollte es auch Platz für einige Anekdoten oder Perlen der Weisheit aus deinem PhD-Projekt haben. Tja, ich glaube, dass an dieser Stelle nochmals in aller Ruhe deponiert werden darf, dass Geduld nicht unbedingt deine größte Stärke war. Und das ist in meinen Augen in deinem Fall auch nicht so verwunderlich. Du hast nämlich selber eine sehr schnelle Auffassungsgabe, kannst sehr gut analytisch denken, hast eine ausgesprochene Arbeitsmoral und willst vorwärts machen. Und ja, da wird man im Publikationsprozess ab und zu mit Editoren und Reviewern konfrontiert, die nach deinem Gusto nicht immer so speditiv antworteten. Ich kann mich noch bei einem der ersten von dir eingereichten Manuskripte erinnern, dass du mich nach 3 Wochen fragtest, ob du nicht eine Reminder an den Verlag schicken solltest. Aber du hast dazugelernt. Am Schluss des Doktorats warst du zähneknirschend, aber durchaus bravourös, imstande bis 4 Monate auf Feedback der Review zu warten. Was gut kommt, braucht Zeit. Und es kam gut, liebe Sabrina. Alle 6 Studien deiner Doktorarbeit hast du in namhafte wissenschaftliche Zeitschriften publizieren können. Respekt nochmals dafür. Während deinem Doktorat hast du außerdem 2 Preise gewonnen. Der eine Preis, der mit 25.000 Schweizer Franken dotierte PhD-Förderpreis der Stiftung Physiotherapie Wissenschaften, konntest du jedoch nicht selber in Empfang nehmen. Du warst nämlich während diesem Anlass im Ausland in den Ferien. Aber vorausdenkend, gut erzogen und anständig, wie du halt bist, hast du eine Videobotschaft mit deinen Dankesworten verfasst. Nach Abspielen dieser Videobotschaft waren einige der Anwesenden im Saal leicht irritiert. Sie sahen nämlich dich, braun gebrannt und entspannt lachend, am Strand auf Mauritius, mit einer Urkunde im Wert von 25.000 Schweizer Franken in der Hand. Und diese Personen meinten irrtümlicherweise, dass du diesen PhD-Förderpreis für Ferien auf einer tropischen Insel eingesetzt hattest. Zugegeben, eine verlockende Idee, aber das war nicht der Fall. Du hast den zweckgebundenen Förderpreis selbstverständlich für dein PhD-Projekt eingesetzt. Aber es war eine lustige Fehlinterpretation. So schnell kann das gehen. Von Seiten des Supervisorenteams kann ich sagen, dass wir immer an dich geglaubt haben und versucht haben, das Beste aus dich herauszuholen. Mit einer Dosis Berner-typischem Understatement wage ich an dieser Stelle sogar zu behaupten, dass uns das gar nicht so schlecht gelungen ist. Bleiben wir doch bei der Bescheidenheit. Jeder Abschluss, auch deine Dissertation, läutet auch wieder einen Neubeginn ein. Und du hast selber bereits vorgesorgt, dass die vermeintliche Forschungslangeweile sich bei dir nicht breit machen wird. Folgeprojekte sind bereits angedacht und zum Teil schon initiiert. Obwohl du dich im Institut für Physiotherapie am Universitätsspital Bern zusätzlich noch enorm einsetzt für die physiotherapeutische Behandlung von Patientinnen nach einer Covid-19-Erkrankung, bleibst du dem von dir so heiß geliebten Fachbereich der Intensivmedizin treu. Intensivmedizin, Intensive Care Unit, ICU, ICU. We see you. Professor Dr. Stefan Jakob und ich freuen uns auf die weitere Zusammenarbeit mit dir. Wir freuen uns wirklich auf die gemeinsame Weiterführung der wissenschaftlichen Unterbauung und Weiterentwicklung der Frühmobilisation auf der Intensivstation. Und noch etwas Persönliches. Es wäre aus meiner Sicht längerfristig durchaus erstrebenswert, zum Beispiel an der Medizinischen Fakultät der Universität Bern, eine Professorin mit einem physiotherapeutischen, intensivmedizinischen Hintergrund zu benennen. ICU, ICU. Setzen wir uns doch neue sportliche Ziele. Ich glaube an dich. Danke, dass ich diesen Weg mit dir gehen durfte. Ich wünsche dir sehr viel Befriedigung und Erfolg bei den Folgeprojekten. Dein Wissenshunger ist noch lange nicht gestillt und das ist gut so. Weiterhin auch viel Erfolg bei der dir so am Herzen liegenden Implementierung deiner Forschungsresultate in der Dienstleistung und in der Lehre. Außerdem wirst du als frisch gewähltes Vorstandsmitglied im sowohl schweizerischen als auch europäischen Verband der Intensivmedizin berufspolitische Erfahrungen sammeln können und unter anderem am Policy-Making-Prozess beteiligt sein. Aber jetzt wird erstmal gefeiert. Es lässt sich mit größter Wahrscheinlichkeit nicht vermeiden, dass du in die nächsten Minuten mit original holländischen kulinarischen Spezialitäten wie Bitterballen konfrontiert wirst. Keine Angst oder Ehrfurcht, auch das wirst du erfolgreich meistern. Einfach nicht auf einmal in den Mund nehmen. Innen drin sind sie meistens brutal heiß. Dann nächste Woche frei von der Arbeit, sich etwas Wellness gönnen und im Sommer mit deiner Mutter Ferien machen. Sabrina, die Welt liegt dir zu Füßen. Nochmals, ganz, ganz herzliche Gratulation. Du kannst richtig, richtig stolz sein auf das, was du erreicht hast.
Ich möchte gerne kontinuieren in englische Sprache. Esteemed Dr. Grossenbacher-Eggmann, dear Sabrina, it's my great pleasure to congratulate you with your doctorate, and I do that also on behalf of the Board of Deans of Maastricht University. And maybe I may share with you some impressions from the committee. We have enjoyed a very clear presentation, and we have seen a thesis which is, I think, comprehensive, well-written, and based on studies of high quality. And we also enjoyed your defense. Your defense was to the point, well prepared, knowledgeable, honest, open, and reflective. And I think these are real compliments to someone who gives a very good defense. And also you have shown that you are well aware of contemporary research. And I would like to congratulate you with that, and also your 4 supervisors sitting here in front of me. Professor Rob de Bie, Dr. Carolien Bastiaanse, Dr. Martin Verra, and Professor Stefan Jacob. Congratulations with this result that we have seen today in an excellent thesis and an excellent defense. And of course, I would like to include in my congratulations your parents, your partner, and other members of the family, which are probably also not all present here in this aula. Congratulations with your family members, and I also would like to congratulate your friends and all the people that have contributed to your studies. And also, and last but not least, I would like to thank your 2 parliamentarians. And I wish you a successful professional career and a happy personal life. I would also like to thank all the members of the 2 committees, the degree committee here present, and also the members of the thesis assessment committee. And in particular, I would like to thank the external members and all the opponents who have posed interesting questions and evoked an interesting academic discussion. Thank you all, and Maastricht University appreciates your contributions and your input. Before I close this ceremony, I would like to give the word to the 2 opponents who are not present live here, but present online. And may I invite you, starting with Professor Prins, to congratulate the young doctor.
Yeah, dear Sabrina, it is really a pleasure to attend this ceremony. Your thesis was excellent, and your defense, as cited by the pro-rector already, was near perfect and also very honest, open. I believe you have a great scientific future. With my congratulations, I also want to include your family and all your friends and those next to you, and also, of course, the supervisory team who should have done excellent work in getting you from an inexperienced trialist to a person who really can defend what she did and knows what she's going to do. Congratulations, and enjoy your rest of the day and life.
Dear Sabrina,
Professor.
Dear Sabrina, I congratulate you from all my heart. You did a tremendous job. I know how hard work at the ICU was during the last years, how many extra shifts and how much we had to do, and you still were able to complete such an excellent piece of scientific work. Today, your presentations was to the point and your defense was very, very good. My hearty congratulations to you and to your family. Enjoy this day, and I wish you all the best for your future scientific career. I have no doubts whatsoever that you will go on working and do more studies and help people getting better in the future.
Thank you, and I would like to thank you again for your input and your contribution to the academic ceremony. Thank you very much. Before I close this ceremony, I would like to mention that we will take a picture here, and we will take a picture in the hall at the stairs. And I would like to ask you to simply sit down until we have made our photograph, and when we go out, you can probably follow the beadle to the place of the reception in the rafter. And hereby I close this academic ceremony.